Hey, it's me, Dr. G. Those who know me know that I will do all that I can to ensure that my patients get the best care with the best doctor they can find. Our health system is not perfect by any stretch of the imagination, and far too often, closing gaps in care is a continual struggle. However, I truly believe that each person fundamentally deserves equal access to high-quality health care regardless of their insurance. The COVID-19 pandemic has exposed numerous inequities in our system, but let me be clear when I say that many health disparities already existed pre-pandemic. As a Black physician, I know too well the disheartening and unfathomable statistics that plague my community. We know that Black Americans have a higher disease burden of hypertension, diabetes, mental health, and obesity rates when compared to other racial and ethnic groups in this country. Furthermore, Black men have the shortest life expectancy of any demographic by far. I've always wondered what is driving this trend. That said, I read an article that was published last week in the journal Hypertension titled Discrimination and Hypertension Risk Among African Americans in the Jackson Heart Study. Here's some quick background on the Jackson Heart Study. It began in 1997, involving more than 5,300 Black men and women in Jackson, Mississippi. It is the largest study of causes of cardiovascular disease in African Americans ever, with the goal of investigating genetic and environmental factors to better understand why Blacks are disproportionately affected by cardiovascular disease. Dr. Alana Ford at the Urban Health Collaborative at Drexel University in Philadelphia, Pennsylvania, and her colleagues looked further into this topic to truly determine whether one possible explanation for this particular disparity is discrimination. Prior to our team's work, few studies had ever examined the association between discrimination and the incidence of hypertension. So they examined whether everyday discrimination, lifetime discrimination, and stress from discrimination were associated with hypertension, and whether these associations differed by gender, age, discrimination attribution, and coping responses to discrimination in the participants. They looked at self-reported discrimination by 1,845 African Americans aged 21 to 85 years without hypertension at baseline. Participants then completed 2 follow-up study visits from 2005 to 2008 and 2009 to 2013. They concluded that 52% of the participants developed hypertension over the follow-up period. After adjusting for several factors, medium and high levels of lifetime discrimination were associated with a higher incidence of hypertension. They also determined that a higher level of stress from lifetime discrimination was associated with higher hypertension risk. So what does this all mean? It means that more work needs to be done. We have to better understand the social determinants of health, in this study that was discrimination, and the people who are disproportionately affected by them. I, as a physician, my physician colleagues, and other members of the broader healthcare community need to create measurable solutions that eliminate barriers to optimal care and provide accessible tools to handle them. We not only have to do better in the communities we serve, but more importantly, have to be more understanding of the individual patients that receive our care. Peace out.